itself. So my name is Michael Harris. I'm an AUA student. I'm a Med 5. I'm starting my clinics in October. I finished my first 2 years top of the class. I got the highest achievement award when I did the whole white coat ceremony. And I, as well as Heather, are doing this program that is available to everyone, right? To help with any concepts or any Med 1, Med 2 through 4, even basic material. Okay. So that's a little bit about me and the program that I have. So let's go ahead and get started. So the first question, what did you guys say was the answer for this one? You guys should have done these questions by now because it's been a week almost. So go ahead and throw in the chat if you can what question you got. If not, I can just go ahead and go through the answers myself and then you can see them. So essentially in this question, it's asking you which, this is most likely caused by the enlarged mediastinal lymph nodes compressing which of the following structures. So essentially this is an individual that's coming in with swelling of her face and arms, okay? Face and arms, which is usually completely disappears by the end of the day. So that means while she's walking around, the actual swelling is going down. Okay, so that means that it's draining while she's up, and only when she's laying down is it clamping on a vessel or clamping on a lymphatic vessel that's causing you to have fluid buildup. Okay, that's essentially what's going on here. So as a result, you end up finding out that it's the SVC. So this right here is what is the big clue to let you know that this is an SVC issue, a superior vena cava syndrome, because the superior vena cava drains the face entirely, as well as both upper limbs. Okay, so that's textbook presentation with an occlusion or some kind of blockage of the superior vena cava. Okay, and you can see that here. We have some blockage of the superior vena cava, and as a result, you have bilateral swelling of the arms and the face. Okay, good. Any questions on that? Just give a thumbs up or a heart, however you want to do it. Okay, let's move on. So for this question here, it's asking us which nerve innervates the pericardium and is responsible for the referred pain. So for this is a big concept for you to know because this is moving on in the path when you go into Med 4, my bad, Med 4. So with that being said, the actual pericardium itself is innervated by that phrenic nerve. C3, C4, C5, right? These are the three three cervical nerves that are innervated the pericardium and leads to the pain that you get with referred pain. And that's why you get it on the shoulders, because that's the dermatome for C3 through C5. Okay? And that's exactly what's going on there. Now, for question 3, I don't know why I didn't pull up the question there. Did you guys get the question here or no? Because on mine, it doesn't. Maybe I deleted it by accident when I was going through it. But for this one here, essentially it's asking us the tumor mass grows posteriorly and thereby most likely compresses which of the following blood vessels immediately posterior to the right main bronchus. So the thing that you have to kind of visual spatially think of is the right main bronchus as well as the left main bronchus. These guys are located right below the T4 vertebrae, right? That sternal angle, that's where they bifurcate and split, right? What else happens at T4 is that you have things like the superior vena cava, entering into the pericardium, stuff like that, right? So the other thing that happens here is the azygous vein drains into the superior vena cava, which then enters into the pericardium, right? Because if the superior vena cava is in the pericardium, how is the azygous vein supposed to drain into it? It can't, because you have that pericardium there. So the azygous vein drains right into this, right into the superior vena cava at this junction, okay? Which is why E is the right answer to this one, okay? Any questions on that? No, pretty good. All right, let's keep moving on. So here we can see this here is the superior vena cava. And just like I was saying, right? The superior vena cava enters into the pericardium at the level of T4, at that sternal angle. Okay. So at that level, you'd have to have the azygous vein drain in first. Because if it doesn't, then you have the issue where the azygous vein has to figure out a whole nother pathway to pierce the pericardium to enter into the superior vena cava. It doesn't work that way. Okay. So your body's going to try the path of least resistance. So it's going to do the azygous vein before entering into the pericardium. Okay. Good. Now, for this one here, this is basically stating which other fine structure that lies immediately posterior to the esophagus between the thoracic aorta and the azygous vein. So this is something that is it's not as important, but is important because you can damage this guy. But the thoracic duct is located at this location between those two guys, right? Between the esophagus and the thoracic aorta. The main thing to remember is that lymphatics always follow arteries. And you should know that by your experience with Med 1 when you went through MSK, right? Lymphatics always followed arteries, right? You always had those bundles, okay? Now, with that being said, that's why this lymphatic or this thoracic duct is right at this location between the thoracic aorta and the azygous vein, okay? Okay, great. Now, the other thing to make sure you remember is where this thoracic duct drains into, okay? Because the thoracic duct essentially drains the left side of the face, the left arm, and the whole entire lower body, right? Only the right side of the face and the right arm is drained by the right lymphatic duct, okay? You're going to talk about that again when you go into Med 3. But these are the various locations that these guys drain, okay? Now, these guys drain particularly into what is known as the venous angles. Okay. Now, the venous angles is where the internal jugular vein and the subclavian vein meet, and right at that spot is where you have the angle located at. Okay. Good. And you can see that here at this location. This here is the subclavian. This here is the internal jugular vein. Okay, so at that junction, you have the thoracic duct on the left, the right lymphatic duct on the right. Okay, great. Now, here's the last question for like the mediastinum stuff. For this one is asking us the thoracic aperture through a small cut made right above.
How you guys?
Hey.
I think it's wait.
I'm sorry. Do you have a question? Okay. Is right above which of the following structures in order to avoid damaging the surrounding neurovasculature and muscles. So essentially here, it's talking about this aspect with location of structures, right? So when you have locations of structures, you have to have some idea of if you're going to be located or essentially what other dangerous structures are around there, right? So the specific structure that you should be worried about when you're looking at the superior thoracic aperture is things like the subclavian veins, because they go essentially over the first rib, right? You have things like the carotid arteries in this superior aperture area. Okay, that's also a very big thing to worry about. That the only main area that you should be is the jugular notch of the sternum. At this specific location, you're going to avoid damaging neurovascular structures because no neurovascular structure travels right here at this jugular notch of the sternum. Okay, so right here at this jugular notch, this little dip, they're located beside it, but never in the middle. Okay, instead, you have things like the trachea, what's located there, but that's like really deep. You have to go deep into that structure to really damage that structure. Okay, and that's why the answer to this one ends up being the jugular notch. And you can see that this here's the jugular notch, and you can see here that all the arteries, let me use black, all the arteries that we're discussing are located laterally. Okay, and then here's our subclavian guys, and we're saying how these guys are also noted laterally and go over the first rib. Okay. Any questions about that? No. Okay, good. Good. Now, the other thing that's also very important to remember is this aspect of trach tubes. Okay. Where you,
Hi, excuse me.
yes,
Quick question. Where is this available to us, this PowerPoint?
yes, everything was, so the questions were already sent to you in the group chat. The only thing that hasn't been sent to you is the answers, and I'm going to send that to you after this meeting.
Oh, okay. Thank you.
Yeah, no worries. So, in this image here, the main thing that is being pointed out is that when you look at ribs, okay, all the neurovascular bundles, right, the nerve, the artery, and the vein travel above the rib. So you always want to go below the rib when you're doing any type of incision or any type of tubing, because you don't want to damage these nerves at this location. Okay. That's the other thing that's very important when you're thinking of the thoracic cage and the mediastinal area. Okay. Great. Any questions on that? Nope. Okay, let's keep moving on. So now we're gonna talk about the anatomy and embryology MCQ questions that was given to you guys. Okay. So these are a little bit more extensive, but we're gonna go over them together. Okay. So in this question, essentially it's asking you, the mediastinal contour obscured by the lung consolidation on this patient's chest rate is primarily formed by which of the following structures? So this is something that you have to walk away with knowing the X-ray imaging, okay? And X-ray imaging is something that's a little bit complex if you try to actually see the structures in front of you, okay? So what I mean by is this. You know the general structure of the heart. Okay. You know the superior vena cava is above the atria, which is above the inferior vena cava. You know the right ventricle is on the right side or anterior portions of the heart, right? And the left ventricle is more on the left side / inferior portions of the heart, right? And the left atrium is on the back base or the posterior portions of the heart. Knowing that, that's how you apply it to this image. Okay. So we can see here, this is the right side versus this is the right side versus the left side. Okay. So if this is our heart, what do you expect this structure here to be all the way up here? It would be the superior vena cava. I don't even have to see what it is because I know, generally speaking, on the right side above the heart is a superior vena cava. Okay. Now, when you're at the level of the heart, this becomes the right atrium because that's what borders the right side of the heart. And on the most inferior portions in the inferior vena cava. Okay. Now, On the left side, you have the left ventricle. The left atrium would be noted inside, right? The base of the heart. And then you got to think also of the arteries that come out of the heart. For instance, the aorta. The aorta comes out, loops, and then travels down. Okay? So this here is your aorta. Okay? Now, the last thing that's missing is the pulmonary vessels with the pulmonary arteries. Now, I'm going to erase a little bit so you can kind of see what I'm pointing at. Now, here in the lungs, you got various areas, and it's a little harder because this is an image that's pathological. It's not like a normal image. But in a normal image, it would be a lot clearer. So what you want to look at is this. You're going to see two different things. You're going to see tubes like this, and these tubes are going to be shaded inwards. Now, the reason why they're shaded is because blood is opaque. That's why the heart is opaque. All right? Versus this that's empty and black. The reason it's black is because that's air. Okay? So this is going to help you differentiate, oh, am I looking at a blood vessel, like a pulmonary trunk or arteries? Or am I looking at something like the trachea and its bronchi? Okay? So when you look here in this image, this is what I mean. This here is a tube, and inside is black. This is air, so this must be the trachea. Now, down here, we have tubes that are shaded in. These are your pulmonary arteries. Okay? Any questions on that? You have to have this general basis of x-rays with the heart. So, with that being said, I've already denoted to you that this must be the right atrium, which is what the answer is. Okay? Let's keep moving on. And just like we discussed, here's the image. Everything we've discussed is in this image. Now, I'm not going to worry about that stuff. Here is these things are extra little tidbits that you can look over to help with anything that you have pertaining to the anatomy, like arterial blood supply, the EKGs, the venous drainage, and whatnot. But let's just keep going because the questions is what more focused on. So in this one is talking about, I'm sorry. And this one is talking about a dissection flap in this patient, most likely originates near which of the following points? So in this question, we're essentially trying to figure out what dissection flap are they talking about, first of all, right? Because we don't know what dissection flap. So when we read this, it's several hours, he's hypertension, He has a transesophageal echocardiogram, so it's a dissection flap in the descending aorta, but no evidence of dissection in the ascending aorta. Okay, so we're looking for something that's only a portion of the descending aorta. Okay, so as a result, you're looking for what is known as the left subclavian artery, because if you look at the arch of the aorta, you have the brachiocephalic trunk, followed by the internal carotid artery, right, on the left, followed by the left subclavian artery. Okay, the left subclavian artery is essentially noted on the descending portion. Any questions on any of that? Nope, pretty good. Now, this is a lot of extra details going on here of stuff that you don't need to really worry about as of yet, because this is what is known as an aortic dissection. And you'll learn that later. Okay. All right. So left subclavian, just like we've discussed. And here is an image of what an aortic dissection is. Do you have to worry about it now? No. Okay. but the anatomy portion you should know. Okay. All right, good. Now, there are a variety of other arteries that you have to make sure that you don't forget about, right? The arteries that come from the external carotid artery and the internal carotid artery and their branches. Now, let's continue. Here on this next question is asking us, during the procedure, the surgeon should plan on ligating a derivative of which of the following embryologic structures? So, what embryologic structure or what ligating are you doing? So I can figure out what this is coming from. So it's saying a 4-year-old boy is first aware, his teacher is tired. Okay. So we have bounding peripheral pulses, peripheral thrill below the clavicle, near the left upper sternal border. Okay. So we're kind of along this area. And there's a continuous murmur here. Okay. So this is what is known as a PDA, patent ductus arteriosus. So essentially what's ending up happening here is that this patient has a opening that's still persisting from the sixth arch. Okay. And that's essentially what this continuous murmur is all about. Now, you guys are just now kind of finishing up with or starting up with murmurs and trying to figure out a little bit with murmurs, with like systolic versus diastolic murmurs, regurgitation versus stenosis and stuff like that, right? So don't beat yourself up if this is something that you may have missed, because you guys are just learning it this week, I believe. And yeah, a fellow student confirmed it. You just learned it today, which is great, you know? So this is the stuff that essentially is what going on is this PDA, and this PDA is part of the sixth aortic arch. You have 1 through 6. However, 5 degenerates. Okay? So this is the general outflow of your aortic arches, and they form different things. But a big way to remember it is that it forms head to heart. So what I mean by that is the head is with arch 1 and the heart is with arch 6 being the PDA or the pulmonary arteries. Okay? Any questions on that? Pretty straightforward. And this here is showing us the same breakdown where you have things like the maxillary artery, you have things like the stapedial artery. This is where your head is located at. And then you get closer and closer to the heart where you get to the pulmonary arteries. Okay? Good. Now, here's our next question. And this question is essentially asking us which of the following coronary arteries is most likely included in this patient. So, in this patient, we have damage to the inferior surface of the heart. So that means the inferior surface of the heart is supplied by what artery? Right? The inferior surface of the heart ends up being supplied by the right coronary artery. Okay. 70 to 80% of the time. Right? Because you're right-sided dominant. So it's right coronary artery. They do not have a posterior descending artery, which is essentially the artery that innervates the inferior surface of the heart, but they do have the right coronary artery. Okay, good. Now, just like we discussed, here's a posterior descending artery or the posterior interventricular artery. And with that being said, there's a vein. Let me ask these guys a question because you guys should know this. There's a vein that travels with this artery. Does anyone know what that vein is? What's the vein that travels with this artery? Good. The middle cardiac vein. Yes. Good. And then you have things like the great cardiac vein here and the small cardiac vein. Okay. Great job. That's another thing that they could pull out and ask you questions on, right? They could show you or identify an artery for you and then ask a simple question like, what vein accompanies this artery? Okay. So make sure you don't forget that stuff because that's very important. All right. So here in this image is asking you the type of collagen seen in an autopsy sample is most likely to be extensively found in which of the following normal body tissues. So this is an image of what is known as collagen. Okay. So with this being noted as collagen, there's only one main place that you're going to find this. Okay. Which is in tendons. Okay. Good. Any questions on any of this so far? I know I'm kind of moving quite quick. I hope I'm not losing people. Do you want me to slow down a little bit? Or are we good? Because I don't want to waste your guys' time. Okay, because essentially you guys got these questions ahead of time. All right, so with this one, it's essentially asking us which of the following structures is most likely injured in this patient. Okay, so now we need to know, well, where is the damage? So we can figure out what structure is most likely damaged. So sees a severe thunderstorm, large tree branch fell through a window, fragments, lost control, shows a deep penetrating wound in the fourth intercostal space along the left sternal border. So it's a left sternal border. I'm sorry. It's a left sternal border, and it's damaging the fourth intercostal space. So as such, there's only one main structure that's most likely to be here, because always on the anterior surface of the heart is the right ventricle. So that's your answer, right ventricle. And that's how they're going to ask a question pertaining to damaging this right ventricle, right? It's always going to be peristernally left-sided, not right-sided, right? Because the right side would be the lungs, left-sided is a heart, and that's how you damage it. Now, the right side, you could damage structures like the inferior vena cava and the superior vena cava, but very unlikely to damage the atria itself. Okay, because the atria itself is like right kind of behind and like very close to the sternum. The superior and inferior vena cava are more likely to get damaged than the atria. But here it's all ventricle because it's left-sided. Okay, perfect. Now, here is this presentation, and you can kind of see how this right atria is really nice and tucked away, whereas the superior vena cava and the inferior vena cava are a little bit more exposed. So they're the ones that are more likely to get damaged versus like a right atrium. Okay. Good. So now here's the next question. So they're asking you the highest value is most likely recorded from which of the following vessels? So this is a fetus. We see a value of 67. So with that being said, what structure do you think has the most oxygenated blood out of all of these guys? It ends up being the inferior vena cava. Because the superior vena cava, right, is something that is going to be coming from the limbs, going to the heart. So this is actually the least oxygenated blood. Okay. Even more so than the umbilical arteries going to the umbilical cord. And then you have things like the descending aorta, the umbilical arteries, and whatnot. But the superior vena cava has literally the least oxygen in the body. Okay. Now, the reason why that is because of this. So here's an image of the heart. Attaching to the right atrium would have been the superior vena cava, right? Now, when you look at the aorta, it's getting oxygenated blood mixing. which is why the O2 level here is higher than the O2 level here, because this is draining of all the blood from the upper limb and the face. So essentially, this is not 100%, but highly deoxygenated blood. Okay, good. Any questions on that? And this is why the superior vena cava has the least oxygen in the whole body in a fetus. Okay, let's keep moving on. And here's another image, and you can see how blue the superior vena cava is compared to the rest of the body. All right. So here, this is the next question that is coming on.
Yeah.
That's nice.
Yeah. The mom is just like a mom.
Okay, so this is the next question, right? So in this question, it's talking about the pressure reading from the procedure most likely corresponds to which of the following pressures. So with this one, we have to then sit down and be like, oh, okay, well, where are you located at? Okay, so what essentially they're saying is they're doing a balloon tip catheter. This balloon tip catheter is also known as a Swan-Ganz catheter. Right? And as such, this measures the left atrial pressure. All right. Any questions on that? We can see that here. When you lodge it into the pulmonary arteries, you're testing the left atrium, known as a Swan-Ganz catheter. Okay. Now, here's the next question. In this question, they're essentially saying this patient finding typically suggests compromised blood flow through which of the following coronary arteries. So I don't know what coronary artery it is yet, because it's just saying compromised blood flow. So what's going on in the vignette? Well, what's going on is that this patient reveals a rupture of the posterior medial papillary muscle. This posterior medial papillary muscle is very unique because it only gets one blood supply. This is on the left side, okay? But on this guy, you only get supplied by the posterior descending artery, okay? The anterior medial papillary muscle is supplied by two arteries, the left circumflex and the left anterior descending artery. These both supply that anterior papillary muscle. So whenever you get one blood supply, you have to be very attentive to remember it, because these are areas that if anything happens to this artery, this structure will get damaged, which is exactly what ends up happening in this example, where this patient has a posterior descending artery damage that ends up leading to the posterior medial papillary muscle being damaged and died. Okay, which is why you end up with regurgitation. This is something you're going to talk more about moving on into Med 3 and Med 4, but this is kind of just the anatomy portion. Good, posterior descending. Now, here is kind of showing you the different structures that is supplied by each one of these arteries. Okay, the ones to really pay attention to is the left anterior descending, in particular to the interventricular septum. You need to know that the left anterior descending supplies how much of the interventricular septum? Two-thirds. The anterior two-thirds, while the posterior descending artery supplies the posterior one-third. So the left anterior descending supplies a lot of the interventricular septum. Okay, good. Now, there are other things that you need to make sure you know pertaining to what each thing supplies. For instance, the right coronary artery supplies the SA node, while the PDA supplies things like the AV node. That's also very important to know. Okay. Any questions on any of that before we move on? No? Okay. We'll just keep moving. Moving and a grooving. So in this one, which of the following is the most likely cause of the observed finding in this patient? So we have to first find out what is the observed finding. So in this patient, we have sudden onset right arm pain, or arm weakness, my bad, difficulty speaking, and you see an acute infarction in the left frontal lobe, agitated normal saline in the peripheral vein, and bubbles are seen passing. So you see bubbles passing into the left side of the heart. So for some reason, the right side has some connection to the left side of the heart. Because essentially, the right side should drain into the lungs. And then the lungs, it goes back to the left side of the heart. However, there are certain conditions that there's a communication between the left and right side of the heart. Okay. As such, this is known as a septal defect. Okay. An atrial septal defect. This is known as incomplete fusion of the atrial septum primum and secundum. Okay. Any questions on this one? This one's a little bit more complex. I don't expect you to see this type of question, but the concepts that you guys have discussed is just applying to it. Okay, it's nothing really new to it. It's just applying to it in a concept that you don't know what the actual diagnosis is. But this right here, you should be able to understand why right heart, left heart, nothing should be passing between those unless there's an opening. Okay. Like a patent interatrial septum. Okay. Good. So now this here is the embryology of the septum. Make sure you understand why you have septum primum followed by septum secundum, and you have ostium secundum followed, or ostium primum, I should say, followed by ostium secundum, followed by foramen ovale. Okay. Foramen ovale then becomes fossa ovalis when they are born. Okay. Good. And this structure here is at endocardial cushions. So this is where it really comes into understanding what endocardial cushions form. They form the and what I like to do is just draw a box, right? If it goes up, it forms the atria. If it travels down, it forms the ventricles, the VSD, right? Like the membranous portion of the interventricular septum. If it travels outwards, then you form the valves, the AV valves. Okay. And the only one that's last is the one that comes out of the paper to form that conotruncal septum that forms the outflow tract. Okay. And that's how I remembered it on what these endocardial cushions form. All right. And make sure you remember that it's neurocrest derived. Now, whenever you have damage to these endocardial cushions, a variety of things can happen. For instance, you can have a VSD. Here's our box. We just don't have the downward displacement. Okay. Truncus arteriosus. Now, in this aspect of it, you just don't have the upward or downward displacement of it. Okay. That's why you have a VSD also. All right. And then the last one is this PDA, which is this patent ductus arteriosus. Now, when it comes to embryology, since this is something that's embryology, to remember the names for what they become, if they tell you the name, it's easy. All it is you're changing duct to ligament. Okay? Ductus arteriosus to ligamentum arteriosum. Okay? Ductus venosus to ligamentum venosum. You're just taking the ductus out and putting the ligament in there because it's a ligament now. Okay? It's very straightforward. on how they named it. All right, great. Now, here, this is the embryology stuff. It's there for you to utilize and look over. Great. Now, here, in this next question, we're asking which of the following sets of laboratory findings is most likely to be seen in this patient. Okay, so that means we have to figure out what's going on in the patient. So in this patient had an MVC, or motor vehicle collision. She's had fractures, a chest tube is placed. Okay. She develops respiratory distress, decreased urine output, persistent bleeding from a chest tube drains, and around the intravenous lines. Now, whenever you have drainage of blood around IV sites, this is what is known as DIC, disseminated intravascular coagulation. Did you guys talk about that in your clotting aspect of stuff? You may not have gone in depth with it, but you should have at least been exposed to DIC. Is that correct, or am I wrong? Okay. Well, that's what DIC is, and that's what this example is talking about in this vignette. Okay. Now, with that being said, in DIC, you're essentially forming multiple clots throughout the body. And these multiple clots throughout the body essentially use up your factors. Okay. It uses up all your clotting factors. It uses up all your anticoagulants. It uses them all up. Okay. So as a result, when you use up all of these factors, you end up being in a situation where all of them are low. Fibrinogen, protein C, factor 8, all of these guys, or factor 7, my bad, factor 7, all of these guys are low because of you constantly forming these clots and breaking them down. Okay. And that's what DIC is all about. All right. Now, this is an example of DIC. You don't have to know all these small details because you're going to learn that stuff later. Okay. But DIC has to deal with utilizing all of your platelet factors, all of them. So then you have literally no clotting factors and no platelets. So when we look at bleeding time, this is increased. When you look at PT and PTT, these are both increased because you burnt through all of it. Okay. All right, great. Now, this here is something you can use to help you remember the mnemonic for the clotting factors. In all honesty, I don't do that. I kind of just do 12, 11, 10 doesn't follow in this. It's in the middle. And then it's 9, 8. And then you just go through that way. But however you want to do it, it's fine. Just have some method to know which is intrinsic versus extrinsic. And then knowing if PT or PTT is the player, right? Because PTT is intrinsic, PT is extrinsic. Okay, good. Now, we won't worry about that. This I will talk about. So the other thing that is very important to make sure that you know with clotting is the process. How the heck do you form a clot? Now, there's two different things that happen when you form a clot. The first thing that happens is known as a primary clot. Okay, so this here is a vasoconstriction that occurs just due to the damage and the trauma. But this is essentially formulating and getting ready to populate what is known as the primary plug, what you see here. Now, primary plug, if anything happens to the primary plug, right? Let's say you get a disorder that decreases the production of primary plugs, such as something like von Willebrand factor disease, okay? Or Bernard-Souliers. Any of those guys that affect the primary plug, you're going to increase bleeding time. Because bleeding time is determined by the primary plug. Okay? So my question to you now is, if you had low platelets, how would that affect your bleeding time? So low platelets would essentially increase your bleeding time because of, yeah, perfect, prolonged or increased. Yeah, exactly. Because that's what essentially is forming these primary plugs. However, your clotting factors, if they decrease or increase, that has no effect to your bleeding time. Okay, bleeding time is only the platelets themselves. Now, here is showing you how the primary platelet plug is formed. Von Willebrand factor binds to the exposed collagen, which then binds to GP1B and goes through that process, right? Now, excuse me, you don't need to know this stuff because you're going to talk about that later, but that's essentially what's going on, and it's due to the platelets getting activated. They release their procoagulant activitants, things like thromboxane A2, things like serotonin, things like calcium, all those guys that help with coagulation, fibrinogen. Okay, good. Now, oh, the other big thing to make sure that you remember is von Willebrand factor is released by a variety of things. One is the liver. Two is the endothelial cells. This is known as the Weibel-Palade bodies. You may have seen them when you were studying, right? The Weibel-Palade bodies. These guys are very important because at this location, von Willebrand factor is bound to factor 8. Okay? So if you decrease von Willebrand factor, you affect factor 8. But that's what's going on here with the Weibel-Palade bodies. All right, let's keep moving on. Okay, so here in this question, we're essentially asking, right, the most likely cause of this patient's problem is what? So this patient has a history of pulmonary embolisms. He's 32 years old. That's not normal. Partial PTT is normal. Okay. And remains unchanged when activated protein C is added to her plasma. So protein C deals with breaking down factors 5 and 8. Okay. 8 is part of the PTT portion. Okay. So if you have any damage to protein C, factor 8 is affected and PTT changes. Okay. Does that make sense so far? Now, with that being said, that means that this patient who's 32 years old, which is abnormal, this is known as a heritable condition. Okay. So it was inherited, and they have what is known as protein C. Okay. Now, what goes on here is protein C binds to factor 5 and 8, right? However, if factor 5, Leiden, is not being broken down, okay, then you end up having what is known as a procoagulable state. Now, you're going to talk more about this later, so don't worry about that. But make sure you at least understand protein C breakdowns 5 and 8. Okay, good. Now, let's continue. These guys, you don't really have to worry about right now. So don't focus so much on that. This was just thrown in there for those of you who want to know more pertaining to like the thrombophilias and stuff like that you will learn later on. Okay, now in this question, they're essentially asking you which of the following gives rise to the cardiac structure closest to the ultrasound probe. What is the inherited condition called? So this is called factor V Leiden deficiency or factor V Leiden mutation. Okay. And it's due to protein C, which normally breaks down 5 and 8, not doing that. Which is why whenever you add protein C, activated protein C, everything's unchanged. Okay? Because 5 isn't getting broken down like it should. Yeah, no worries, no worries. Okay, so here we're looking at the cardiac structure closest to the probe. So we don't know where the probe is. So let's figure out where it is. So the ultrasound probe is directly anterior and placed into the mid-thoracic esophagus. So what's anterior to the esophagus? The left atrium. So what does the left atrium form from? So the left atrium forms from essentially the primary ventricles or primary atria, right? However, that's not an answer choice. So now you have to think about what forms the left atria. What else is in the left atria? You have the pulmonary veins. And what essentially ends up happening is these pulmonary veins get sucked into the left atrium, okay, to form that structure. So it ends up being the primitive pulmonary vein. Okay, so that's what you see in this image here. Okay, these are your pulmonary veins, but essentially it forms initially like this. Like, here's my left atria, okay? And these structures outside would be your pulmonary veins, your primitive pulmonary veins, right? So it ends up happening just like on the right side of the heart. When you start merging in that right sinus horn into the right atrium, the same thing kind of happens on the left side, but with the pulmonary veins. So it's sucking in the pulmonary veins and it starts to be incorporated into the left atrium. Okay. And that's essentially what ends up happening. And that's how you get this image presentation here. Okay. Now, the right common cardinal vein, this is something that ends up becoming like the superior inferior vena cava. So that's why this is not the right answer, because this is on the right side of the heart, not the left, where you'd have the pulmonary circulation. Excuse me. Good. Now, here is showing you more of a comprehensive table of what each thing forms into the adult derivative. But this is the big thing they tested on in this one. Okay, and it doesn't go away. That is an important concept. It's also a pathological finding that you'll find later on. Okay, so which of the following labeled structures is most likely to be much smaller than normal in this patient? Well, what's going on in this patient? So this patient has a history of sickle cell anemia. Sickle cell anemia should tell you already that there's going to be blockage of blood flow. That's what sickle cell anemia does. It blocks blood flow. It clots up the arteries so blood can't flow through them properly. Okay? Now, the main artery or main organ that gets affected is the spleen. Spleen is the main organ that gets affected. Now, with that being said, we can take this image and we can elaborate more about it. Can anyone tell me what B is? We'll start with the easy one. The liver. What's C? If B is the liver, C must be the portal vein. This is something that you guys discussed when you did GI system last semester. Okay. What is E? This is the stomach. What is A? This is known as the intestine. Okay. So these are the different identifications of each structure. Okay. Good. Nice, nice. Just like we discussed. Now, this is a image of the heart at the level of the, I guess you can say T4 area. And the big thing to really get here is how the aorta has those branches that come off of it, being the right and left coronary arteries. And the left coronary artery forms a left anterior descending and a left circumflex. So this area right here would essentially be the left coronary artery before it splits. Okay, but that's essentially what that is showing you. Now, this here is another image that's showing you all the various branches of the artery system, which is also very important to know pertaining to the heart, right? In a CT scan. So make sure you're able to identify this. We see two main bronchi. So we're below T4, right? Yeah. All right, let's keep moving on. Now, here we see one trachea. So we're above T4, which is why we see the arch and the arteries that come off the arch. All right. Now, behind the trachea is the esophagus. That's what this other hole or tube-like structure is. All right. It's always trachea followed by the esophagus, because the most posterior portions of the trachea is a fusion of into the esophagus. Okay. And that is why sometimes when you swallow things, if it's really big, right, you'll feel like almost like you can't breathe for a second as it's traveling down, because it's kind of occluding your trachea as it's coming down into the stomach. Okay. But that's what's going on there with the esophagus and the trachea. All right, good. Now, here's the last question pertaining to the anatomy and embryology. And in this question, we're essentially saying anterior grade flow through which of the following is responsible for perfusion of the lower extremities in this patient. So what's going on in this patient? So this is a patient who has strong pulses at both wrists and weak pulses at both ankles. Why would you have high pulses in the upper extremity, but low pulses in the lower extremity? The only thing that would make sense is if you had a blockage of the artery preventing you from having blood flowing to the lower extremity. This is known as coarctation of the aorta. Okay, this is very textbook for coarctation of the aorta. So as such, what other blood supply, like artery, can bypass and go to the lower extremities? This is known as the internal thoracic arteries, because this internal thoracic artery comes down. And if you remember back in GI, you had an artery that came up in GI system, came up on the anterior abdominal wall, known as the superior epigastric artery. And the superior epigastric artery and the inferior epigastric artery merge together in an anastomosis. And that is how you get blood supply to the lower limbs when you have something known as coarctation of the aorta, which is what you see here. Coarctation of the aorta. So it's a clamping of the aorta, so you can't have blood passing through. So blood passes through this bypassing limb, which is dealing with the internal costal arteries, and this guy here, which is known as the thoracic artery, the internal thoracic artery, which becomes a superior epigastric artery and fuses with the inferior epigastric artery. Okay, so that's how you would get blood supply to the lower limbs. Now, this is something that you don't really have to worry about so much, but this here, you should have a good understanding of. The internal thoracic artery fusing with the superior and inferior epigastric arteries. Okay. Now, that is the last question with embryo and anatomy. Does anyone have any questions on any of that? I know I threw a lot of questions at you, but was just trying to touch on all the concepts that you guys had discussed for that week. Okay. All right, then let's finish this. Let's finish this off, and let's finish off the last portion, which is the hemostasis and coagulation MCQ. Okay, so these are more hemostasis and coagulation questions, and then we'll be done. So it'll be about an hour that you spent with me, and you did over, I want to say like 20 questions with me. So that's not bad. That's like almost a minute and a half. So here in this question, we have this question that's located in this one. That's basically asking you, laboratory studies are shown below. Which of the following is the most likely cause of the findings in this patient? So what's essentially is happening here? Okay, so when you look at the laboratory studies, okay, in conjunction with the vignette, so let's read the vignette. It's running in, she's having menses that lost 10 to 12 days for the past 6 months. Brother has a bleeding disorder. Whenever they say that, you got to think hereditary. Okay? You got to think maybe this is hereditary and needed a blood transfusion after an appendectomy. The patient is otherwise healthy and denies tobacco smoking. Okay. Now we look at the actual lab findings, and we see in the lab findings that the actual platelet number is low. Okay, low platelet count is low. So already I should be thinking to myself that this patient more likely has a high bleeding time, because low platelet count leads to high bleeding time. And what do you know? We are correct. This patient has a high bleeding time. Okay, now we don't know why though yet. It could be von Willebrand factor disease. It could be Bernard-Souliers. It could be Glasgow thrombocythemia. So there's multiple things that it could be. Still, we don't know yet. Okay. However, they do something what is known as a Ristocetin test. A Ristocetin test is essentially testing to see if they can activate the red blood. Oh, no, not red blood. If they can activate the platelets. Okay. So with Ristocetin, they notice that it's abnormal. However, when they give ADP, which is noted after activation, right? ADP is released after activation, then it's normal. So this is telling me that this has to be something wrong with like von Willebrand factor or maybe Bernard-Souliers, something along those areas. And we see the von Willebrand factor is normal, so it cannot be this. So most likely this is Bernard-Souliers disease. As well, it's GP1B. Okay, and that's how you would do it. Now, with that being said, that's how you should approach these questions. Okay, you should approach it in a way that okay, there's a bleeding disorder. It sounds like it's hereditary. Let's look at it a little bit more. What is the lab work showing? This lab work is showing that you have low platelets. That means low bleeding time. Okay. Therefore, this has to be a platelet issue. Okay, not a clotting secondary platelet plug issue. Okay, which is what we end up finding here. Now, as we continue, here's our next question. This question is essentially talking about a 7-day-old boy comes in with multiple bruises and bleeding at the umbilical stump. Okay, he's breastfed, shows a prothrombin time that is 4 times the reference value. So if you have a prothrombin, if you have a PT that's high, is that intrinsic or extrinsic coagulation pathway? Extrinsic coagulation pathway. Nice. So with the extrinsic coagulation pathway, we think of things like factor 7, factor 3, that type of stuff. Okay. However, this guy, factor 7, also is very important because he's formed by vitamin K. Okay. And vitamin K is a big player in a multitude of clotting factors. Can anyone tell me what they are? There's 5 of them. 5 blood factors that you should know that vitamin K deals with. And hint, 7 is one of them. Two. So it's 9, 2, 7, 10 protein CNS. These are the 5 things that you should remember that deals with vitamin K. Okay. And vitamin K deals with formation of gamma carboxyglutamate residues. Okay. Which is why this answer ends up being D. Now, this is something that you would kind of expect to see on your exam day, something along these lines, right? Where you guys should know what vitamin K is, what clotting factors vitamin K forms, and how that can portray itself on a PT-PTT format. Okay? Any questions on that before we move on? All right. So this here is our next question. What is the enzyme? So the enzyme that has to deal with this is, so epoxide reductase is the guy that activates vitamin K. Okay. The one that you're looking for that uses vitamin K is gamma carboxylase. Okay. And it's essentially what this is saying, gamma carboxyglutamate. But epoxide reductase is the guy that forms it, activated vitamin K. I hope that answers your question. Okay, great. So now let's keep going on. So in this one, essentially it's saying which of the following measurements is most likely to be affected by this drug. So there's a drug that is that is given, right? A drug that is given. It's a thrombolytic drug. And they're essentially saying, how's that going to affect these values? If you give something like a thrombolytic. So thrombolytics are things that essentially break down clotting factors. Okay. If you break down clotting factors, you're going to affect both PT and PTT, because PT and PTT are formed from clotting factors, extrinsic and intrinsic. So that's why this is D. Okay. It has nothing to do with the platelet count. Okay. has nothing to do with just doing any one of these guys by themselves. That's why B and C and E is wrong. Now, here's our, I want to say second to last question. So in this question, they're saying the antibodies against which of the following antigens are most likely present in this patient's serum. So we don't know what's going on here, but this patient has nosebleeds. Okay. Whenever you see nosebleeds, you got to start thinking this could be a primary platelet plug issue. Okay. Now, she has said, also says that she easily bruising, excessive heavy bleeding during her periods. She does not take any medications. She has scattered petechiae, also noted as primary platelet plug disorders. And then you see a platelet count low. Okay, makes sense. Bleeding time high. Those go hand in hand. Low platelets, high bleeding time, hand in hand. And then you see increased number of megakaryocytes. Okay, so now they're wanting to know what the heck is going on here. So essentially in this vignette, you're seeing someone who has what is known as Glanzmann thrombasthenia. Now, how do we know that? Now, there's a few things. One, Glanzmann thrombasthenia is something that affects bleeding time, right? Because it's a primary plug issue. So that's why you see this. That's the first thing. Okay. Second thing, this is a primary platelet plug disorder that this patient has, which is why he has or she has things like nosebleeds and petechiae. So this cannot be a clotting factor issue like hemophilia. Cannot be any of those. Okay. So now it's just boils down to a primary platelet plug disorder, which is known as Glanzmann thrombasthenia, with GP2B3A being the guy. Okay. Yeah. I'm trying to figure out if there's anything else. So type 4 collagen, this here is pointing at the possibility of what is known as scurvy. Now, scurvy does not increase your or decrease your platelet count. Scurvy doesn't do that. Okay? Scurvy has no effect on your actual platelet count. It just affects things like your bleeding time. Because if you don't have collagen, then your bleeding time is going to increase. Okay? But that's essentially what's going on there with scurvy, which is why E is not the right answer for this one. All right, good. Now, these are all the various characteristics for the corresponding disorders and diseases. Do you need to make sure that you understand all these guys? Not really. The big thing to make sure you know is what the heck is going on with things like von Willebrand's disease, right? You got platelet count, you got PT, PTT, how the bleeding time is changed and affected, as well as these guys being Bernard Suyers and Glanzmann thrombasthenia. Okay, now that ends our session for today. I know I kind of went quite fast, and I apologize for that if I went fast for some of you. I just wanted to make sure that we went over all these questions, and I really showed you like the high points for each one of these guys. Now, does anybody have any questions about today's 3 MCQ blocks? I will post the recording inside the group chat for you guys to also watch again if needed. But you also get the PowerPoint as well. All right. So I wish you guys the best of luck. I will send out another question MCQs for next week, Wednesday. And we'll keep going. And then I want to see you guys have a quiz coming up. When's you guys' quiz? Let me stop this recording.